Hi everyone, my name is Jason Galan. I'm a national account manager here with Ametros. We're located right in the Boston area. Today we're going to be talking about the top 5 misconceptions about Medicare set-asides. And we have a panel of experts here. We're going to kind of talk about some of our member experiences, our experience as a company dealing with CMS as often as we do, and just kind of some misconceptions and thoughts that might not actually be true and what life is like post-settlement for the injured individual. So starting around the horn with our panel of experts, I'll let Anna Parks introduce herself.
Hello, my name is Anna Parks. I've been with Ametros for 3 years. I'm the assistant manager for member care. I work alongside of Donna Crawford, who's our manager, and I am also working with the development team with all the enhancements to the operations side of member care.
Great. And Kathleen Correa.
Hi, I'm Kathy Correa. I've been with Ametros for about a year and a half. I'm the senior claims manager, and what I and my team do are process provider bills and ensure Medicare compliance. So we review the bills to make sure the services that are coming through are Medicare covered for MSA accounts.
And Matt Labella.
Hi, I'm Matt Labella. I've been with Ametros for a year and a half now. My area of expertise is on the pharmacy side of things. I'm the RX team lead. I'm also nationally certified by the Board of Pharmacy as a technician. I help with the pharmacy team day to day and with all prescription claims that come in for members utilizing medications for their injury.
And last but not least, Robin Kavanaugh.
Thank you. I've been with the company about a year and a half, and I'm the voice of the customer team lead and working with members all day long, trying to solve any issues that they have and trying to get them what they need while keeping them compliant.
Yeah. And I do want to point out, we've grown so much as a company over the past 6 years. And as you can see from the kind of gamut of folks that we have on the call, that we've changed so much that we have a voice of the customer who is the injured worker that's on our platform. And there's such a variety of things that we're doing that day one we weren't. And it's helped us not only grow for our clients on the defense side and on the plaintiff side, but also really at our core, helping our injured individual members throughout the post-settlement life. So we're going to get started here. The first misconception I'm going to point to Kathy Correa here is the Medicare set-aside funds will cover anything. And so I think helping our listeners and viewers understand what they will cover, but also what to do if they won't be covered.
Hi, so a lot of the questions that we get and a lot of the services that our members look for are not Medicare covered. One of the things that we see a lot is home health care. There's personal care attendant services. Home health is only covered on occasion for intermittent use, but there are aspects of home health that are covered, like physical therapy, occupational therapy. Those things can all be done in the home. So there are a lot of things that can be done in the home. Skilled nursing is a very brief intermittent period, so it's not an everyday benefit. People that need someone to come in on a daily basis and do blood work or wash the dishes or, all of those chores and things like that, those are not things that Medicare covers. Another thing that we see a lot of is incontinence supplies. We have a lot of patients, we have a lot of members that need incontinence supplies, and anything disposable, Medicare doesn't cover. So when we see that they need incontinence supplies, we try to look elsewhere. We try to go through one of our vendors and see if we can get them a lower price and they can cash pay. But there are so many things that are not Medicare covered that it's really difficult for people to understand what it is they can and cannot get.
That's really helpful. And, what would you say, like the average, when someone comes on board, what is kind of this thought of what is next for them when they become a member with us and what this Medicare set-aside is? Because I know when I started working at Ametros, I'm sure every one of us had no idea what an MSA was, right?
Right. So a Medicare set-aside is an account that's put aside at settlement to pay for injury-related Medicare covered services. So anything that is Medicare covered and related to the injury, we can pay for out of that account. The important thing about keeping that account compliant, actually there are several important things, but the biggest, most important thing is these funds that are set aside need to be exhausted before any other Medicare can pay any of these other benefits. So if you misuse your Medicare set aside, Medicare can say, we're not going to treat you until you make up that money that you've misspent. So if we don't keep our members compliant, when they do get to Medicare, Medicare will not pay for any injury-related services if that MSA was not used properly. So it's really important that we keep them in line. And everyone is going to eventually be on Medicare. There are lots of ways to be eligible for Medicare. It's not necessarily age-related. So we need to ensure that if the account is exhausted, it's exhausted correctly, because we do annually report to Medicare, so they do see what we have paid for out of those accounts.
Great. Yeah. All right. So the second misconception we're going to talk about today is how can this money be spent? So not necessarily will the Medicare set aside funds cover everything or anything. It's really more towards, what does Medicare pay for? What is the injured individual responsible for paying for? And how does Ametros interact to make sure that those things get paid for appropriately, as well as, what happens on a timeline of when the case settles to 20 years from now for the injured individual?
Okay. Yeah. So once the member settles and they come on board with CareGuard, we get their settlement funds, we get all their doctors onboarded, we call their pharmacy, and then the way everybody settles differently. Everybody's account is different. Everybody's allocations are different. And in your MSA would be listed what your injuries are, treatment that would be covered, any DME items that would be covered, any prescriptions that you need that are all Medicare compliant. Those are all listed in your MSA. And that is sort of our guide on how we take care of the individual. Everybody's different, no one's the same. And that's our guideline on how to keep the account compliant. And so, their future Medicare wouldn't be interrupted.
I would like to say also, there's always sometimes where there's an MSA. So if it is sent to CMS, that's the one that we go based off of. And we do know that treatment changes over time, but we basically base it off of the diagnostic. So whatever the codes that we have that say the injured body, that's what we would go based off of. And sometimes we'll see that they might have just one medication listed on their account, where then later on the doctor might prescribe them other medications. As long as it's related to the injury and Medicare covered, we will continue to pay for the services that they have rendered.
Yeah. Thank you, Anna, and thank you, Robin. I guess along that is, what is this misconception that, the MSA pays for this, but then what about the co-pays that happen if someone exhausts? Can you talk a little bit about that and what the reality is? Because the thought is, if the person runs out, they're going to have to pay 20% of the value, which, it's almost like 20% of nothing, because we don't know what that number is going to be, right?
Right.
So kind of just talk about the interaction with Ametros and, Medicare set-asides and co-pays in general.
Okay. So if the account is appropriately exhausted, and then in any given year, most of our members have an annuity, and they get a certain amount of money every year that will cover their treatment. And on occasion, a member may exhaust their funds before their next annual payment comes in, and they'll have to use their other insurance. Sometimes that is Medicare, sometimes it's something different. We'll use Medicare as the example. And when you're using your Medicare, the member would be responsible for 20%. And that is their responsibility. We cannot reimburse co-pays from this account, from an MSA account. And I think a lot of the members think that before they come on board, that we can reimburse for co-pays, but we can't do that.
A lot of the times we do see that the member was told that they won't come out of pocket ever again. And they're like, why am I paying for this? It should come out of my account. Once your funds have depleted, that time frame is the next annual funding. If it's a structured settlement, we won't be able to use those because those are for the next year of treatment. So that was why, one, and two, Medicare doesn't cover co-payments anyways. So being compliant, we wouldn't be able to cover that as well.
Right. And I guess too, one thing that, well, is there any difference if the person self-administers? Can they use this MSA money for copays?
No. I mean, that's our job. We get hired to keep the account compliant so they don't jeopardize their future Medicare coverage. If somebody was self-administering their own funds and was spending it on things that aren't compliant, they would be at risk.
And that's the reason that professional administration should always be recommended, because the average person doesn't know what Medicare will and will not cover. So if you are not currently a Medicare beneficiary, you can't pick the phone and call Medicare and say, hey, what are my benefits? Because you're not a beneficiary. So it's really difficult for the layperson to understand how to keep themselves compliant. It's complex. It's very complex.
We send the toolkit to our members and the workers' comp toolkit for the MSA, and it's 30 something pages, and it's very detailed on how to self-administer these funds. Sometimes they come back and say, I don't want anything to do with this because it's so detailed of what they have to take account for. We have so many departments that just for that administration, and to be able to get that completed and be compliant with their settlement and what workers comp MSA is. So when we see that a person is self-administrating, sometimes self-administrated individuals come on our platform on their own because it's too much for them to handle as well.
Yeah, like you said, 36 pages of directions to self-administer seems like a lot for the average person.
Right. And it's not direct too about options that are out there for discounts and everything like that, which is a huge part of what we provide, right? So I know Matt's going to be talking a little bit about that. So to kind of move on to the third section of the misconception is, Medicare, the idea that Medicare isn't a part of this, and that, my settlement funds have nothing to do with Medicare. I'm not a current Medicare beneficiary. I can just use my spouse's insurance. So Anna's going to kind of explain why that's not true and what we do to kind of answer those questions and support those individuals better.
We've had conversations with members where they, don't understand where Medicare comes into play once they settle, especially being a workers' comp case, right? They're saying this money was for my injury at work. What does Medicare have to do with this? I'm not even on Medicare. So some people are not, even though they're eligible at some point in time, they haven't hit that mark yet, or they are not in the criteria to have Medicare. So they're basically saying, I have Blue Cross Blue Shield, for example. They have private insurance, and they're like, why does Medicare matter? And at some point or another, we're all going to end up on Medicare. So Medicare takes into account as a secondary payer when in the Medicare Secondary Payer Act, because they were paying previously at some point in time for these workers' comp injuries, and they're like, wait, you have money set aside. Let's have this money used first. Once we see that you're using this and you're being compliant, then you'll be able to use these funds. We'll pay for anything once you're depleted or once the funds exhaust completely. And that does affect their future funds, because if they are not being compliant while they have this money set aside, Medicare can stop their treatment for anything related to the injury when they deplete or they exhaust. Medicare won't cover anything that's related to their injury until they pay back anything that was used that wasn't compliant with Medicare. So when that happens, it ends up them paying out of pocket more, because they have to use their money out of pocket to cover these expenses, because it wouldn't be covered. We also see that with other private insurances too. We have gotten lien letters from other insurances saying, hey, should have been covered by us. Why is this being paid? And we have to we try to reverse the bills, see if we can be paid as primary. and it becomes like a cycle.
And I guess this question for the group, have we ever helped an individual who has come on board post-settlement that was misusing their funds and actually had to pay Medicare back? And how has that worked out?
We do get a lot of lien letters, conditional payments, and those are typically prior to settlement, but we do get things that come through that are after settlement, when what we have to, they will get like a letter saying you have to pay this by an X amount of date or you'll get a penalty. And what we have to do is basically, if it is before settlement, reach out to the carrier, send that to them, see if they can pay those bills. But anything that's prior, we'll reach out to the doctors, ask them, hey, is there something that you can do to reverse those bills? We should have been paid, charged as primary, not Medicare.
Yeah, we'll actually reach out to the provider and say, can you return that money to Medicare and send the bill to us instead? And that's the only way to resolve something like that. Because we tell the provider, you know, this is the account that should have been primary. There are no co-pays. There's no co-insurance. Please resubmit the bill to us, refund Medicare, and we'll pay for it. So that's how we mitigate the conditional lien situation, is we actually ask them to bill us instead.
Yeah, that's good to know. And it's important to understand that our position in conditional liens is post-settlement. We don't deal with that pre-settlement at all. That's a different responsibility that a lot of Medicare set-aside allocators do. But I did want to mention that, you know, probably 2 or 3 years ago when we really became aware of Medicare denying claims was when we received the first letter that said, Medicare is denying this claim because you have funds set aside for your MSA. And this was an individual who was self-administering an MSA. And we actually helped them reimburse the doctor, pay the doctors, and properly exhaust their funds so this individual could be compliant and continue to treat. So moving on to misconception number 4, Matt, treatment, the misconception is my treatment's never going to change. You know, I'm treating a little bit today. I'm never going to get any worse, right? Or, you know I have to take a few medications and I go to the doctor. I know that I can pay out of pocket and I won't misuse any of these funds. Can you kind of just talk about some interactions you've seen where, you know, the unexpected occurs, or whether it's a surgery or someone starts taking a prescription that was not originally allocated, and how we deal with that?
Yeah, so that is a great misconception that RX prescription regimens or treatment plans will never change. A lot of times they do. That you could be on a certain amount of medications or a certain script for quite some time. The doctor could change that at any moment. It could be a more expensive medication. It could be a cheaper medication. But we want to always keep an eye on that, and that's what we do for the members. Say if a regimen did change and there was a different medication thrown in there, we would help bring down the cost of that drug, but also inform the member of different options of pharmacies that you could use where we could find the best pricing for them, or or a network of pharmacies. But also just keep in sight that you're spending this much on prescriptions now, this is what could possibly happen, and just keep them in the loop of things so they get an understanding of a regimen change and how it could affect them.
So kind of just to keep going on the trend of discussing how treatments won't change, we did have a case study for one of our members. Leslie Porter was her name. And can we talk about how we helped her when her treatment regimen did change, and kind of what that interaction was like?
So I came upon a member that was actively, let's say, depleting their funds throughout the year because they were allocated a certain amount of medications to be, yearly, and her regimen did change where she was on, say if, I couldn't remember exactly, say if she was allocated, they said, you're going to be on these 3 medications throughout the year. I know that regimen did change and she was on more, and it went up to maybe 5 or so. And that was she was facing depletion of her account because paying for extra medications that weren't set aside for. What we did was found a pharmacy in network with a cheaper cost, and we could obtain those drugs at a much lesser amount, thus stretching her settlement funds throughout the year. And it was definitely a big win because she's not facing depletion anymore and is still obtaining those drugs and treating her injury.
So Matt,
That's really helpful.
there
That's
was
interesting
another
to
one.
know.
I think that there was another one that you helped me out on. One of the members, I can't remember the medication that she was receiving, but it was being done at the provider's office.
So a member was getting a certain treatment for injections, and the doctor's office was billing for the injections, basically 2 times the cost than we could get it through a pharmacy. So we worked out a plan where found a pharmacy where it was about $1,500 less, had the drug shipped to the member's doctor's office with their approval, got the drug for about half the cost, and then they just billed for doing the injection itself. I think we saved the member $1,500 or so, and it was well below their allocation. It was a home run.
And it was $1,500 each time. I think that service was being provided monthly.
Yeah.
So if you look at that over the course of a year, you saved her quite a bit of money.
Yep, definitely.
Just to include on the MSA allocations, there's typically a formula and there's like units, there's milligrams and a cost that's typically like an average on that medication. And we do get calls from members saying the medication is higher than what I was allocated for. What is this? And it depends on the pharmacy, it depends on the manufacturer. And I think that Matt can elaborate a little bit more on how does that work and how we work to try to get that reduced to closer to what was allocated for.
Yeah, so it really depends on what pharmacy is stocking what at the moment. We will always get a discount on a drug, but prices vary. There's a million manufacturers out there for every drug, and all costs are different. So if I see something that is not aligning with an MSA, a Medicare set aside, I will actively try, or myself or the team will actively try to get that drug at the same cost that aligns with the member settlement, either close to it or below, pricing wise.
That's great. That's really helpful. And it's important to understand too what Matt just said, where we're always getting some form of a discount for the injured individual that out of pocket and just walking in off the street they might not be able to get. And there are a lot of misconceptions on other kind of ways to get discounts, but in terms of bundling the compliance with savings, that's really where CareGuard, our professional administration product niche is. So just to move on to the last kind of misconception here, how these Medicare set-asides and medical settlements are funded. This idea of, can I get more money from the insurance company? I don't think this is enough, but the case is already settled. What's kind of the interaction with the member like? And I point to Robin for that question.
We do get that question a fair amount of the time. There's times where member needs a surgery that wasn't planned for, and they don't want to have to use Medicare to pay for the surgery because they don't have enough funds in their account, and they'll call us and say, can you put some more money into my account? They don't realize that we don't, if it's a structured annuity, they don't always realize that we get that when they see it in their account. We get that annually. We're not getting the full lump sum. So no, we cannot get more money into your account. Once it's settled and the annuity is written into that, that's how it is. That set amount is going to be what they're getting every year. We can't add to that.
We see that with lump sums as well, where lump sums they run out of their funds and they say, can we add more? And we're like, nope, that's what you got. That happens often too. But that's one that we do see where they ask us to dip into the funds for the following year or once they're depleted to cover it.
And there are reasons not to dip into that next upcoming annuity. So when funds are exhausted, when an MSA exhausts their funds or temporarily depletes their funds for the year, we actually send that notification to Medicare. We send a notification saying that the funds have been exhausted for this year. We tell them when the account is expected to fund again. So when we send Medicare that notification, that signals to Medicare that they should start paying for the member's work-related treatment. So it's important because what we're doing is we're telling Medicare, this is your responsibility now. So we don't want to go back and take out money from the next year for something that Medicare has to accept responsibility for. So it's really important that we don't pull from the next year's annuity.
And then just a piece on when they do have to use their Medicare and they have that 20% copay. We've had conversations with members about getting supplemental insurance so they don't get stuck with the big 20% copay, and they wouldn't have to worry about that. That's most of the concern when they flip to Medicare if their funds deplete in any given year.
And the other part of
Right.
it that I just want to add is that sometimes when they have an MSA, they believe that they are automatically enrolled into Medicare. We get that also where they depleted their account and they go to the pharmacy and they say, Medicare's denying my medications, and they're not using Medicare Part D, or they're not enrolled in Part D, or they're like, I thought I was enrolled automatically because I have Part A, Part B, or other vice versa. They thought they automatically got it once they settled that and they had a Medicare set aside, that they didn't have to enroll. You still have to enroll in Medicare regardless.
Yeah, and so that's a really great point. And I guess question for this group, realizing that less than 3% of our members exhaust every year, but what's the process like when a member doesn't exhaust, and are we there, even though we're not paying bills for them, are we there to answer questions and kind of support them through, the transition and even when their claims are being handled by Medicare for a period of time?
Yeah, we absolutely, they're still a member. Just because their funds have exhausted temporarily doesn't mean that we don't still manage them and help them with things. Another thing that we do a lot of, even though it is for a small percentage of our members, is if we see that a patient has been treating with a pain management provider regularly or a different, physical therapist regularly, oftentimes they'll still continue to send, they'll send us the bill, and then we have to deny it and say, you need to submit this to Medicare. So at that time, they'll pick up the phone and call us, and we generally have a conversation with them. We still want to see the bills. They should still submit the bills to us, but then they're going to need to submit to Medicare as a secondary payer. But we have conversations with the member, we have conversations with the provider, because like I said, and this is why people should always look to professional administration. The whole coordination of benefits thing is also complicated. Not everyone has Medicare. Some people have a commercial plan through their husband or wife. So there's a lot of nuances in managing this whole thing.
Right. Great point about that. I mean, we often have conversations with individuals pre-settlement, and they say, I don't need to worry about this MSA. I'm on my significant other's insurance. So that's a great point.
I had a
Yeah.
case study that was working with a member, I think it was when I first started, and he did not qualify for Medicare. He actually didn't qualify to be on Medicare, but he had a non-Medicare account and he was depleting it, and he needed home health care consistently throughout the year. And we found a way to be able to get it covered and get him discounts while he was depleted to try to get that try to find a way to fix his account. It took us over a year to get him there, so that way he'll be able to have it consistently and not continue to deplete over and over and make it a cycle. But it was those members also we work with that don't have Medicare or can't be eligible for that, to try to see if we can find other ways or means assistance from their city, their state, or other organizations that we can kind of send them to that can help them work for their cost that they're going to be paying out of pocket.
That's interesting. I didn't even know that, so that's really good to know. All right, so that was the last misconception. So thank you everyone for attending, and thank you to our panelists. As a reminder, we are always available pre-settlement to talk through all these different things and answer any questions for injured individuals, attorneys alike. So never hesitate to reach out, and we're always here to help. So thank you very much.